Hi, I am Dr. Saqib Mansoor, and this is my channel Learning Anatomy. And as you know, I have started with you a series of lectures on the spinal cord anatomy, and that normal anatomy is already finished. And now my focus is on the clinical. Some of the videos are already uploaded, and today I'm going to upload this Babinski sign, Chaddock sign, Oppenheim sign, Gordon sign, which all are elicited to prove there is lesion in the upper motor neuron lesion. So whenever there is a upper motor neuron lesion, we see these four signs. First of all, this is the Babinski sign, and also the Chaddock sign, and Oppenheim sign, and the Gordon sign. And I will discuss in detail. So the most well-known sign associated with the upper motor neuron syndrome is the extensor plantar or Babinski response or Babinski sign, right? Also known as extensor plantar response. So it is normally present in infants before the corticospinal tract is fully myelinated and functional, right? So in infants, the Babinski sign is present and it is normal. So let's see what happens in this Babinski sign. So this is a normal plantar response as the lateral aspect of the sole going there up till this point of the metatarsophalangeal joints. It is stroked sharply. So this thumb and the other fingers, toes, this thumb and the toes all flexed. Is all flexed. Their toes go down. This is the normal plantar response. And what happens? This Babinski sign of the extensor plantar response, as the lateral side of the toe, lateral side of the sole is scratched upwards and bluntly and with some force. What happens? This toes go upward, and this is the dorsiflexion of the great toe, right? Dorsiflexion, and the rest of the four toes they fan outside, right? This is the thing. That is the thing. That's the point. This is a post pasted over here. So the great toe becomes dorsally flexed and the other toes fan outward in response to scratching the skin along the lateral aspect of the sole of the foot. The normal response I told you already. It's look like that. So what is the criteria of Babinski sign? Lesions of the spinal cord interrupt a number of the descending tracts, which is basically upper motor neurons collectively they are called, and produce characteristic signs that are evident after the acute effects have dissipated or disappeared. These include the following Babinski sign, first of all, which may be based on the following criteria. So these are the four criteria. Number one, upward movement of the great toe is pathological only if caused by contraction of the extensor hallucis longus muscle, right? And number two, contraction of the extensor hallucis longus muscle is pathologic only. It is pathologic only if it is occurring synchronously with the reflex activity in other flexor muscles, for example, those of the toes, right? And third, a Babinski sign does not necessarily imply that the concurrent activity of the other flexor muscles should be brisk and vice versa. And the last criterion is the true Babinski sign is reproducible, unlike withdrawal of the toes, right? You can always produce that sign, the Babinski sign, whenever there is a upper motor neuron lesion. So upper motor neuron lesion signs, for example, hyperflexia and Babinski sign, all these signs I have a separate video, the upper motor neuron lesions. I've already discussed all the signs and symptoms produced by the upper and the lower neuron, upper motor neuron and lower motor neuron lesions. These are seen in the ipsilateral muscles innervated by the nerves originating from cord segments below the level of the lesion. So note that for upper motor neuron lesion signs to occur, the lower motor neuron must be functioning. It's very important, this line. So in two other conditions, we can also see the Babinski sign. One is the amyotrophic lateral sclerosis, and the second is the subacute combined degeneration of the posterolateral sclerosis. Plantar stimulation must be carried out far laterally in the S1 root or the sural nerve sensory distribution. Here, far lateral, not this medial, not this medial. This is the farthest lateral here, possible as far as lateral as far, right? This one, this is the S1 segment, the sural nerve area. More medial plantar stimulation. What will happen if it is stroked medially? It may fail to elicit a positive response when one is present. For medial stimulation may actually elicit a plantar grasp response, causing the toes to flex strongly. The stimulus should begin near the heel and be carried up the side of the foot at a deliberate pace, but too quickly, and usually stopping at the metatarsophalangeal joints, right? The response has usually occurred by the time the stimulus reaches the mid portion of the foot. As it reaches here, the response is normally initiated and produced. If it does not occur, we should carry it till that level here, right, upper level, and then to medially to this side at the end of this the second digit, this metatarsophalangeal joint. If the response is difficult to obtain, the stimulus should continue along the metatarsal pad from the little toe medially. I told you already, but stopping short of the base of the great toe. It should not go base of the great toe. It must stop at the base of the second toe. So the most common mistakes, what are clinically these are done in producing the Babinski sign: insufficiently firm stimulation, placement of the stimulus too medially, and moving the stimulus too quickly so that the response does not have time to develop, right? So there should be a sustained and moderate pace. The only movements of significance are those of the great toe. The most important movement of this Babinski sign, this whole setting, is that of the great toe, which is, dorsiflexion. Fanning of the lateral toes without an abnormal movement of the great toe is seldom of any clinical significance, and an absence of fanning does not negate the significance of great toe extension. So what should be the position of the patient and the position of the foot in eliciting the Babinski sign? The patient should be relaxed and forewarned of the potential discomfort, as we have to scratch it. The knee must be extended. It's a very clinically and in neuroanatomy and neurology, very important concern for the patients. Why to give this painful stimulus to the patient? That's a separate discussion, which I will not do here in this small lecture. The knee must be extended, and upgoing toe may be abolished by flexion of the knee. The best position is supine, with hips and knees in extension and heels resting on the bed. Some neurologists will only check the plantar responses with the patient recumbent, right? If the patient is seated, the knee should be extended with the foot held either in the examiner's hand or on her knee, on his or her knee. The response may sometimes be the response may sometimes be reinforced by rotating the patient's head to the opposite side. It may be inhibited when foot is cold and increased when the foot is warm. So for some discussion about some three other signs, first of all, that is the Chaddock sign, and what is their significance? If the Babinski sign is difficult to obtain, or we have to confirm the Babinski sign, three other signs are use: Chaddock sign, the Oppenheim test, and the Gordon sign. So what is the Chaddock sign? It is elicited by stimulating the lateral aspect of the foot, not the sole, beginning about under the lateral malleolus near the junction of the dorsal and plantar skin. drawing the stimulus from the heel forward to the small toe. Here you could see this is the Chaddock sign, right? This is the lateral malleolus, and from here towards the small and little finger, the little small toe, and this is produced the Chaddock sign. So, right, what happens? The response is that of the way this is what is seen in the Babinski sign. So this is the thing, and this is reverse Chaddock. The stimulus moves from the small toe towards the heel. It will be moving from here, small toe towards the heel, right? The Chaddock is the only alternative toe sign that is truly useful. It may be more sensitive than the Babinski, but is less specific. More sensitive, but less specific. Then the Oppenheim sign. The Oppenheim sign is usually elicited by dragging the knuckles heavily down the anteromedial surface of the tibia from the infrapatellar region to the ankle. The response is slow and often occurs towards the end of the stimulation. Yes, you could see this is the knee, this is below anterolateral surface of the tibia, and the knuckles are been drawn over here towards the ankle, right? And then this is the response, same as in the your Babinski sign. A common ploy is to combine the Oppenheim and the Babinski sign to make a suspicious toe declare itself, but this is more painful and less useful than the Chaddock. Then in the last, Gordon reflex. The Gordon describes an extensor plantar response when the calf muscle is squeezed. Here you could see this squeezing of the calf muscle, and there is the Babinski sign features are produced. Dorsiflexion of the great toe and the small toes fan outside. The Gordon reflex is very simple to complete and can be of use in determining lesion localization. The clinical sign is used to determine whether a lesion of the pyramidal tract exists. I told you already, these are all four signs. The Babinski sign, the Gordon sign, the Chaddock sign, the Oppenheim sign are used to elicit this upper motor neuron lesions. So this is the way. Thank you very much for this. This is very important, four signs clinically. And I hope you have enjoyed watching the video. So all students of the anatomy and the neuroanatomy and the neurology. So I thank you very much for watching my video. And please, I request you like and subscribe my channel. And please like and do comment down below. So take good care of you, stay safe, and bye.